What is the Matrix? Control. The Matrix is a computer-generated dream world, built to keep us under control in order to change a human being into this.
Hyperkalemia causes an electrical short circuit in the muscles of your body. Every one of our most basic functions are initiated and controlled by the voltage changes both inside and outside the cell membrane. The difference between these voltages is known as the membrane potential. Potassium is a positively charged electrolyte and has the ability to alter the membrane potential. As we explore the danger of hyperkalemia, keep in mind two terms. The first term is electrolyte, meaning an element that carries its own electrical charge. The second term is voltage-gated channel. Essentially, these are doorways into your cell membrane that open and close based on the present voltage either inside or outside the membrane wall. Our journey will take us into the cell to actually learn how these charged ions affect contraction, then on to define some of the causes of hyperkalemia, and finally, we will review the current treatment options. When the cell receives an electrical nerve impulse changing the extracellular voltage, the voltage-gated channels open or close, allowing selected electrolytes to diffuse in and out of the cell. This causes a shift in the voltage, opening and closing more voltage-gated channels, triggering additional reactions, such as the release of calcium that indirectly causes contraction. It should be noted here that the movement of electrolytes is not only controlled by the diffusion against the concentration gradient, but also affected by the voltage gradient created by other electrolytes with like or opposite charges. This graph represents the electrical activity or action potential of an individual muscle cell during depolarization. The primary electrolytes are potassium, sodium, and calcium. Depending on the cell, the voltage while at rest is about negative 70 millivolts, and this is called the resting potential. However, to say that muscle cells are at rest is a misnomer. They are in fact in a constant state of flux. There are structures in the membrane wall called leak channels. These channels are not voltage sensitive, but they are specific to a particular ion or compound and allow free passage through the cell membrane. However, as a positively charged potassium ion diffuses out of the cell through the leak channels from higher concentration to lower concentration outside the cell, the intracellular chloride with its negative charge pulls back on the exiting potassium, restricting its movement. As if that were not enough, sodium leak channels allow positively charged sodium ions to leak into the cell, but sodium has no opposing electrical gradient, so yet another structure in the membrane wall kicks in. The sodium-potassium pump. This pump acts in opposition to all of these concentration gradients, pushing sodium out and pulling potassium back in. This pump requires ATP and is responsible for 40% of your daily energy needs. When all this works together, the net resulting electrical charge is called the resting potential. Now here is where it all comes together. Threshold potential is the specific voltage needed to open those voltage-gated channels and achieve an action potential which will cause depolarization. Remember, anytime the resting potential meets the threshold potential, depolarization will occur. We have just explored the action potential of the common skeletal muscle. Now let's take a look at the heart muscle. Here we see our regular skeletal muscle side by side with a section of myocardial muscle. The heart muscle cell, or myocyte, differs from the common striated muscle cell in that it is laid out in a V pattern. This is because myocytes are branched and directly attached to all other myocytes by a strong binding fiber called intercalated discs. In addition, inside these intercalated discs are tunnels called gap junctions that allow electrolytes to pass freely between the cells. This accounts for the very rapid and orderly transmission of the electrochemical reaction initiating the action potential in the next cell down the line. In short, because of this layout, once one cell in the myocardium is stimulated, then the next cell in the branch is stimulated, and so on until all cells have been depolarized in a specific order. This is a graph representing the action potential of an individual myocyte. You can see at the top of the action potential at phase 1, the curve seems to flatten out for a period before beginning repolarization. The reason for this is because at a specific voltage during the action potential, additional calcium stores are released and flood the sarcomere in order to assure full contraction of the cell and in effect delaying the time until the cell can repolarize. As a result, the cell cannot contract again before all other myocytes depolarize. This is known as the absolute refractory period. One more thing you need to observe is the timeline. While the entire action takes 200 milliseconds or 0.2 seconds, you can see phase 0 takes only a small portion and represents the QRS complex on the EKG at about 60 milliseconds or 0.06 seconds, which is a normal duration for a healthy adult QRS. The threshold potential in the myocyte is closely regulated and maintained at 15 millivolts difference from the resting potential. An interesting question arises here as we look at this chart. We can see in phase 4, this myocyte or working cell of the heart has a very stable resting potential. Unless acted upon by a nerve impulse or some other means, how could the resting potential ever meet the action potential to fire by itself and become the dominant pacemaker for the heart? The answer is it can't. However, there are two types of myocytes, one called the working cell, which is represented here, and another group of cells called pacer cells. Here is the action potential of a pacer cell. You see immediately it is very different from the working cell in that phase 4 never remains flat and over time, if not acted upon, will reach threshold sparking an action potential. This is because the pacer cell specifically has a special structure called the HCN2 pump, which allows for a constant influx of sodium ions that begin to lower the negative charge, raising the resting potential closer and closer to the threshold potential at negative 40 millivolts, when voltage-gated calcium channels open, allowing calcium to rush in and rapidly trigger an action potential. At the peak voltage of about 10 millivolts, the calcium channel closes and the potassium channel opens, allowing positively charged potassium ions to escape the cell, neutralizing the voltage. This is very different from the working cell in the heart, which uses only sodium to raise the resting potential and calcium to delay repolarization. What would happen to the pacer cell if we were to introduce a way of blocking or limiting the influx of calcium? Hence, calcium channel blockers. Here is where all the pacer cells of the heart are located. Pacer cells act independently. If not otherwise stimulated by an outside force, each will eventually generate their own action potential. How then, if they all act independently, does our heart beat in such an organized fashion? The answer is overdrive pacing. The SA node is the dominant pacemaker and continues to send a signal down the proper pathways and depolarize all the pacer cells along the way before the HCN2 pump can raise the resting potential enough to cause an independent action potential. The SA node, in essence, is overriding or overdriving, as we call it, the slower intrinsic rate of that specific pacer cell. But again, if for some reason the pacer cell doesn't receive an external signal, it will fire independently. And this can be seen as a PVC or PAC on the EKG. And if it fires shortly after the absolute refractory period, in the relative refractory period, you may cause ventricular tachycardia. Now here you see the normal action potential of the working myocyte in solid black, overlaid with the dotted black line representing the change in action potential that hyperkalemia causes. Notice how close the resting potential is to the threshold potential and the widening of phase 0. This will show on the EKG as a widening QRS, a shortening of the QT segment, and a loss of the P wave. Remember, as potassium levels rise, the resting potential becomes closer and closer to the threshold potential. And what happens when the resting potential meets the threshold potential? The first EKG sign of hyperkalemia is peaked T waves and usually appears once potassium levels go around 6 milliequivalents per liter. The second sign is prolonged PR interval, which can be seen at levels around 7. Absent P waves and a widened QRS complex is the third manifestation and is a very dangerous sign. It means that atrial activity is lost and the stage is set for ventricular tachycardia or fibrillation. It is usually seen at a level around 8 or 9 milliequivalents per liter. So pay attention to your ACLS H's and T's, one of which is hyperkalemia. How do we know who has hyperkalemia? In trying to develop hyperkalemia as a presumptive diagnosis, barring any trauma involving a crush injury, you should have a high index for patients with any type of renal failure or bowel obstruction, as these are the only two mechanisms by which the body can eliminate excess potassium. Next, elicit a good history and take note of any of these listed findings. Lastly, bear in mind that although we can develop hyperkalemia from a crush injury, the crushing itself is not the culprit, but instead it is the consistent long-term pressure on the muscle tissue, very much like that of a bedridden patient who has developed pressure sores as a result of poor long-term care while in bed. In addition to disease states, many medications can contribute to the development of hyperkalemia. Beta blockers and digoxin, by their very mechanism of action, inhibit the uptake of potassium from the extracellular space. Be aware of the patient in a junctional bradycardia with peak T waves and ectopy. Your patient could be suffering from both dig toxicity and hyperkalemia. In addition, people are often prescribed potassium-sparing diuretics or ACE inhibitors like lotensin, and others often result in potassium retention. Correcting hyperkalemia is based on three main tenets. The first is stabilization of the membrane potential. Second is the restoration of the electrolytic balance. And third, the elimination of excess potassium, in that order. Here is the short list of mainstream medications currently used in EMS to correct hyperkalemia. In the setting of hyperkalemia, the resting membrane potential will become less negative, closing the gap between it and the threshold potential, increasing myocyte excitability. When calcium is given, the threshold potential then becomes less negative, restoring the 15 millivolt gap and reducing the myocyte excitability. There are two concerns when administering calcium. The first is for those services that do not carry calcium gluconate. Be aware that calcium chloride is 3 times more potent and can be considered irritating to the myocardium. Calcium chloride has also been known to cause tissue necrosis and is generally reserved for injection through a central line. However, clinical evidence shows that diluting it in a 50 cc bag and running it through an IV drip has been an acceptable alternative for those who do not carry calcium gluconate. The second concern is a fear of inducing the syndrome of rock heart in those patients suffering from hyperkalemia as an untoward effect of their digoxin prescription. The theory has a certain face validity. Digoxin inhibits the sodium-potassium pump, increasing intracellular sodium and calcium in the myocardium. Since calcium causes myocardial contraction, it is not illogical to believe that the increase in intracellular levels of calcium would produce irreversible contraction. However, a retrospective study conducted by Levine M. et al. Disputes this and also points out that there has been no clinical evidence to back this claim. After the administration of calcium, the next goal of treatment is to shift potassium back into the cell. This is most frequently done by giving insulin. Insulin stimulates the sodium-potassium pump, which moves potassium intracellular in exchange for sodium. This effect is independent of insulin's effect on glucose. However, additional glucose is generally given concurrently with insulin to assure the patient will not become hypoglycemic. 10 units of intravenous insulin is typically given, followed by a close monitoring of serum blood glucose. 50 milliliters of a D50 solution is frequently co-administered with insulin in a normal glycemic patient to prevent hypoglycemia. If a patient is already hyperglycemic, supplemental glucose is not needed. The effect of insulin is seen within 10 to 20 minutes of administration and can be expected to decrease potassium levels by 0.6 to 1 milliequivalents per liter. Albuterol activates the sodium-potassium pump through beta-2 receptor stimulation, similar to that of insulin. Studies here in the U.S. suggest that 10 to 20 milligrams of nebulized high-dose albuterol had an immediate effect on the lowering of the potassium, rivaling that of insulin, with no adverse cardiac effects. For those of you that don't carry high-dose albuterol, evidence suggests, according to a paper written in Wales, England, that any albuterol is better than none, so it is recommended that you make the diagnosis early and start continuous neb treatments as soon as possible. Sodium bicarbonate infusion can shift potassium from the extracellular to the intracellular space by increasing blood pH. However, routine bicarbonate therapy for the treatment of hyperkalemia is controversial. In a study by Bloomberg and Associates, 12 dialysis patients with potassium greater than 5.25 received intravenous sodium bicarbonate over a 6-hour period. No change in potassium levels was seen until 4 hours after the drug administration, and at 6 hours, the decrease in potassium level was only 0.35 milliequivalents per liter. The study goes on to recommend, due to the lack of quick and sustained decrement in the potassium levels, physicians should reserve the use of intravenous sodium bicarbonate for the treatment of hyperkalemia for situations wherein severe acidemia is present. Ion exchange resins such as Kayexolate 50 grams can be administered orally or rectally and works in the gut by exchanging sodium for potassium, and then the potassium is excreted. Most studies have found exchange resins to decrease serum potassium levels by about 1 milliequivalent per liter over a 24-hour period. Exchange resins can cause significant constipation and are typically given in combination with a laxative such as sorbitol. Not only does the laxative prevent constipation, but it also promotes the elimination of potassium from the gut once it binds to the resin. Although generally safe, the combination of resin and sorbitol has been reported to cause intestinal necrosis, and as such should be used cautiously and only when necessary. Lasix at 20 to 40 milligrams IV can also be used and may be safer than ion exchange resins. However, Lasix is dependent on a healthy functioning kidney, and remember, the patient most often afflicted with hyperkalemia is one who also has renal failure. It should be noted here that contrary to popular belief, the onset of action with Lasix is instantaneous, as are its effects on the patient. However, the patient oftentimes does not have the need to void until some 15 or 20 minutes later after their bladder is now full. It is this filling time of the bladder which leads to the debate over the onset of action. Glucagon, while not specifically used for the treatment of hyperkalemia, may in fact play a role in your course of treatment. Remember, some patients may have to be treated for more than one affliction at a time. Let's take a look at this EKG. Here is an EKG showing no P wave and a peaked T wave as a result of hyperkalemia. Here is another EKG showing no P wave and a peaked T wave as a result of a beta blocker overdose. However, this EKG shows a slow rate, and hyperkalemia is not oftentimes associated with a bradycardia. While hyperkalemia still may be the culprit here, remember to refer to the patient's history, including their med list, to check for any beta blocker or calcium channel blockers. And if the patient is symptomatic, treat for the corresponding overdose. And if the EKG does not resolve itself, then you may want to move forward and treat for hyperkalemia.